Ben, did you want to do any intro to start?
Well, I want to welcome everyone in the room. There's 5 of us, and also those on the Zoom call. Why don't we begin by introducing ourselves in the room, and then I'll ask Tracy to just go ahead and list folks that are on the Zoom. Okay. I'm Ben Steffen, Executive Director of the Healthcare Commission.
Good afternoon, Kathy Weiss, also with the commission staff.
Hi, I'm Peggy Funk. I'm the Executive Director for the Hospice and Palliative Care Network of Maryland. Hi, Tracy DeShields with the Maryland Healthcare Commission.
Linda Cole, Maryland Healthcare Commission. And Tracy, and let us know who's online.
Sure. So, what do I have? Dr. Garney.
Correct.
Oh, thank you. Anna Maria, sorry, Anna, I'm not sure how to pronounce your name. It's Guerdo Barata. Janine Boland. Oh, thank you. Heather Gary. That's Guerrieri. Okay. Joanna Ruth, Dr. Grant, Marion Grant, Monica Escalante, Rebecca Swain Eng, Stacy House, Kathy Hamill, and Winnie Hawk for now.
Okay, welcome everyone again, and we'll begin with just a couple updates on are there comments and questions on the or additions to the June meeting summary?
Yeah. Anyway, I want to welcome, echo Ben's welcome to the 6th meeting of the Palliative Care Work Group. As I mentioned in the mailing, we anticipate this will be the last work group meeting as we wrap things up in preparation for the final report. And we do appreciate your ongoing participation in the process. So first, were there any comments on the summary, the meeting summary from the June 28th meeting? And also we sent the interim report that was forwarded to the General Assembly and the governor in July. So were there any comments or questions on either the meeting summary or the interim report? See any?
No.
Okay. All right. In terms of the recommendations, we discussed an initial draft at the June meeting. And following that meeting, I asked for any written comments from the work group members. I did not receive any additional comments. We conferred with HSCRC and we discussed some of the initiatives with the National Academy for State Health Policy, NASHP. And in addition, on August 4th, we sent the revised draft recommendations to 4 state agencies, the Maryland Department of Health, Maryland Medicaid, the Maryland Department of Aging, and the Office of Healthcare Quality, all of whom were named within the recommendations. We heard back from them and modified the draft recommendations accordingly, and we'll be discussing that a bit later in our agenda. So I'd like to move on to the outline of the final report. Both the interim report and the final report should be standalone documents, so we can certainly reference earlier reports. Some of what is addressed in the interim report will be covered in the final report, such as the background on the legislation, the formation of the work group, and the process for fulfilling the legislative mandate. The new areas to be covered include the results of the survey, the finding from the literature and other states, and recommendations. I should also mention that there will be an executive summary at the beginning of the final report. So as presented here on this slide, Chapter 1 would describe the legislative background and process. Chapter 2 would include background on the evolution of palliative care services and some literature review. And Chapter 3 would address the survey process and some selected results from the survey. So are there any questions? All right. Chapter 4 would include the environmental scan, including palliative care developments nationally and in other states. And what was distributed to you as the states table, which we will discuss later, is a distillation of the environmental scan. And then the final chapter would include the issues and recommendations. And the recommendations, as outlined here, address the issue areas outlined in the legislation. So I will pause for any comments, questions. Again, can you see? See these? Yep. Okay. We move.
I think we can move forward, hearing no comments. Just a point that we typically for legislative reports do break out the recommendations, which is the key product of this work group that the legislators are going to see. Haven't decided yet whether that's going to be a standalone, an additional standalone document, or it will simply be included in the report and referenced in the executive summary. We found that oftentimes having a short document just listing the recommendations, to the extent they're self-explanatory, are much easier for legislators in the midst of a 90-day session to review. But we'll kind of make a call on that as we proceed a little further.
I guess we can see if the executive summary and then the recommendations chapter kind of address that.
Go ahead, Linda.
Okay.
Any questions?
All right, so we'd now like to focus on the meat of the report and the focus of this meeting, which is the recommendations. And as Ben mentioned, some people will be interested in reading about the entire process. Others would prefer to focus on the executive summary and the recommendation. So again, this was sent out in advance so that you could read it in detail. And we welcome any specific comments, questions, or recommendations on wording. So the first set of recommendations deals with public education. And as Dr. Kearney had mentioned in our June meeting, we don't want to recreate the wheel. We basically want to coordinate with existing programs. Also, the Maryland Department of Aging expressed support for this report, but said that they mentioned Maryland Access Point as their focus for community-based services. They also suggested what became recommendation 1B, which is making sure that community providers, including Maryland Access Point, have access and knowledge of palliative care services so that they can make the appropriate referrals. So any comments or wording recommendations on the public education 1A through 1D?
Yes.
Go ahead.
May I make a comment? Community-based providers can also provide primary care. So they should not only know how to refer, but how to develop services around this area. So I would like to add to assure they can refer or create their own service section would be a good addition to 1B.
It's unclear when you say create your own vehicle. What we're trying to do is develop a directory of palliative care providers who we've surveyed who meet the CAPC definition. And so the goal here is to make sure that the community, people in the community like Maryland Access Point know of those providers so that they can make the referrals.
Okay. And
Hey,
you-
Linda, Dr. Kearney, Maryland Access Point is not well known to me. Do you know more about it, or who are they?
Do we have someone on from the Department of
Right.
Aging?
Yes, you do. Hi, can you hear
Amanda.
me?
Yes.
Hi, this is Amanda DeStefano. I work for the Maryland Department of Aging, and I actually oversee Maryland Access Point, and made this recommendation to include Maryland Access Point to Secretary Roque, and she agreed when making the response to the group. Maryland Access Point is the no wrong door entry for long-term services and supports, and serves as the network of aging and disability resource centers here in Maryland. Maryland Access Point staff are embedded in area agency on agings across our state. There are 20 different offices serving all of Maryland's counties, and they provide information, assistance, and referral to individuals who are seeking services in the community, and they connect individuals to a variety of services and supports. In working in Maryland Access Point, this particular network of individuals are regularly interfacing with older adults and those living with disability in the community who need a support with activities of daily living and would benefit from palliative care. And this particular network is not, at this point, well informed about palliative care and who to make referrals for palliative care to. So this particular recommendation was made in light of that.
Okay, thank you.
Of
Yeah.
course.
Peggy, did you have a?
Thanks, Linda, I do. So just in looking at 1A, my recommendation would be that, given the fact that community associations have been so heavily involved in this work group, that we also be added to the list, not separately, but just as community organizations. So it would be State Advisory Council, community associations, and then the
What
rest.
do you mean by community association?
So I think like the Hospice and Palliative Care Network of Maryland, I think potentially Minka, maybe Lifespan. I think it's important to have the support of all of the community associations to help develop these programs.
Okay.
So I guess I think what resources would the associations, not individual members of the association, but I'm thinking you're saying the associations themselves would
Well,
play a role, not.
yeah, Ben, I think I can't speak for the other associations, but I know the Hospice and Palliative Care Network of Maryland does a lot of community education. So I think we certainly could be a resource for helping with this project.
Thank you.
Yeah, sure.
Right, see, anything else on?
So a question for our friends from the Department of Aging. You mentioned 20 out of the 25 jurisdictions in Maryland have Maryland Access Point activities, or there are 4 or 5 jurisdictions that do not. Is that correct, or are they in the process of being established, or are they for some of the rural community jurisdictions shared across several jurisdictions?
So our area agency on aging network in Maryland is the home of Maryland Access Point. And the area agency on aging network has 2 area agencies on aging that serve multi-counties. So Upper Shore Aging and MAC both serve multiple counties. Maryland Access Point services are offered to every county in Maryland.
Thank you.
And it very well could be with these 2 recommendations, and I see, the point of adding other community organizations or community-based organizations to recommendation 1A. It may be that the evidence-based programming is developed outside the Department of Aging, and the Department of Aging is then part of 1B and implementing that evidence-based programming. If specifically calling out Maryland Access Point is part of the sticky point for 1A, it may just make sense to include MAP as one part of 1B and not 1A.
Okay,
Because it seems like 1A is more about developing the evidence-based programming and education, and B is more about who you're educating.
I think we're getting feedback from what
getting an echo.
if someone has the phone on.
It's echoing. Okay, two. The next section.
Linda, I just wanted to note that this is Marion Grant, that I posted in the chat that I do agree with Peggy. There are additional organizations that we should at least acknowledge without naming all of them in 1A. And I can think of funders like the Horizon Foundation in Howard County and other, the Montgomery County Coalition. There are groups that would help in this effort that we can't name them all, but I think we should at least acknowledge them.
Okay. So community association.
Yes. Community professional or community associations, I think, would cover it.
Thank you. Moving to the provider education component.
We skipped over 1C and 1D.
Well, I asked for comments on all of public education.
Okay.
On the provider education, what we're trying to do is address the lack of trained and credentialed palliative care providers by working with educational programs, residency programs, fellowships, and credentialing. And I know, I think both Peggy and Marion had mentioned under 2B, possible loan forgiveness as another option that maybe could be included there, but we'll see if there are any other comments from the work.
Yeah.
This is
Dr. Grant.
Yes, so I have a question. And Linda and I have talked about this separately. I think it's a lovely idea to ask for compliance reporting with the nursing programs. This is going to be, the state has no authority over curriculum in the nursing programs or in the medical programs, right? Yeah, Chris is shaking his head. So I think, I know that for instance, in the state of Massachusetts, that coalition has persuaded all of the nursing and medical schools that this should be part of their curriculum, but that we don't have any authority to do so. So I think we just have to recognize that, I'm not sure how we would do this, but it's a worthy goal, and I think it should be in the recommendation. We just have to think about how we would actually execute that.
So does Maryland higher education?
You can't have your phone on.
The Maryland higher education have authority?
I don't believe so. When I worked at the University of Maryland School of Nursing and worked on curriculum, we were responsible to national accreditation bodies, but to my knowledge, we were not responsible to state ones.
Yeah.
Hey, this is Erin Davis. Since 2018, the Board of Nursing has put in minimum criteria for different practicums and what they have to do. I don't know the specifics. I'm not an expert on it, but they do have some authority over the education for nursing, at least.
Okay. So then we could keep it as written if that's the case. Peggy?
Yeah, I mean, I'm not sure if this is the route, but I do remember when we were all talking about cultural competency, that there was some statute that was passed for various professional boards a couple years ago. So I don't know if you'd have to put something like this in statute or not, but it may be worth investigating.
What was the question
About
So, who has authority over,
Curriculum development.
the curriculum.
Well, would be, the Board of Nursing. Yeah, to a degree. And then, so if you wanted to include that, you could
We wouldn't
say, or you could just say it in legislation that the School of Nursing, blah, blah, blah.
like we did for the cultural competency, right? But then, of course, we're not just addressing nursing either. I think we need to address physicians.
that's why it's written as healthcare practitioners.
Gotcha.
Professionals, and not singling out medical nursing. I mean, they were listed there.
Right.
And then, under 2B, where I know you had brought up the loan forgiveness, I guess we could include that under the last sentence.
Right, and the comment that we received from one of our members, one of our physician members, is that there are some states that offer programs that do have sort of a loan forgiveness if you spend so much time in the field. And we do it for other professions, so perhaps we could look into that as well.
I think Dr. Grant had mentioned something similar in her comments.
If you're gonna look at loan forgiveness, you may also want to look at J1 placing, because a lot of the providers that are of foreign origin may choose a career in palliative if they can stay in the US. So just some food for thought.
Can I ask just briefly about the Maryland Higher Education Commission? I'm not familiar with them, frankly, in the medical training at all either. Is anybody on this committee is representing them?
No, I think it was just a way of dealing with how to address all kinds of educational requirements. So that wording was suggested, I think, at our last meeting. Ben, did you have any other on this section?
No, I did not.
See any? The next area is financing, and after discussing the programs in other states with NASHB and then reviewing possible approaches with Maryland Medicaid, the best approach seemed to be first under 3A, a review of possible options, but then specifically in 3B, integrating palliative care within Maryland's Medicaid state plan and requiring MCOs to provide palliative care under managed care contracts. We'll continue to work with NASHB in the second year of a 2-year project, and also review including palliative care under the newly expanded PACE program. So it's recently expanded from one site, which it's been forever, to now there are 4 additional sites. So
May I ask for clarification on 3B? So Care for Your Health has a community-based bilingual palliative program, but it's tied to primary care, not tied to hospice. So the MCOs are already paying for palliative care. Are you actually asking for that to be paid, like for the palliative care programs and the hospice organizations?
no, No, according to, we discussed it with the Maryland Medicaid director, and it's not covering palliative care per se as an option under MCOs. This was an addition to the Maryland state plan. And that was our conversation.
Now, palliative care service.
Yeah, I think this builds on work that other states are doing. So there is not a palliative care benefit that is part of the Maryland Medicaid program. And other states have sought to do that by doing state plan amendments or changing their Medicaid waivers.
That's correct.
Right now, in a fee-for-service, a provider, palliative care, they're paying.
Somebody else.
They're not just paying for a benefit.
Somebody has phone on or an extra computer, we can't hear what's being said.
So what I'm saying is that when the primary care is provided by a physician or a nurse practitioner under fee-for-service, E&M coding, they are actually paying it right now. So if what Dr. Grant was saying about talking about the benefit and the wording of this may need some rewording.
Well, I think that. Sorry.
You have your phone? No. Sorry, so what were you saying?
I think you're both right. I think that palliative care services can be billed as E&M services, but I think we're talking about a broader carve out of a benefit which is defined in the contracts that the MCOs have with the state of Maryland, that there would be a defined benefit. It wouldn't be left to the individual providers to say, you know, it works for, I can provide this service through a E&M code, and I think 99215 is the appropriate code. And that broadly covers the services I'm going to provide. I think that's where work group members are correct, but there's nothing defined that an MCO must have a palliative care program. So if we could ask people to mute their phones if they're not speaking, somehow we're picking up some chatter from the work group. We can't detect that necessarily, but it is very irritating.
I just wanted to build on this. So you are correct that you can bill for palliative care under fee-for-service, but you can't bill for a lot of what ideally would be delivered, and you can't have members of the interdisciplinary team be paid under fee-for-service. So that what states have done with the Medicaid benefit is they have sought a per member per month payment for a defined population for a defined set of services, which is a much more holistic way of providing palliative care than the hit or miss that we currently are all trying to do. And Peggy can speak to her members who are trying to do it under fee-for-service. It's just not financially sustainable, and it doesn't allow you to have a robust interdisciplinary program.
So I agree, but we need to change the wording to reflect exactly what you said. You know, a carve out or however you want to say it, because if I read this and I'm already.
So maybe instead of providing palliative care services, we would say palliative care benefit or something like that. That would be, yes, I think you're right.
Yeah, I think Marion is absolutely correct. I think that's what we're all looking for, is a palliative care benefits.
Exactly.
That is defined and also covered, right? And so that is part of what we are also working on in the Nashby Institute. Does that make sense?
Yeah, so Marion, was that under B, 3B?
Yes, I think under B, if we just say provide a palliative care benefit under their managed, then I think we've got it a little bit more defined. Details still to be worked out, obviously, but yeah.
I think that, sorry, Joanna, Ruth, jumping in for Medicaid really quickly. I think that makes more sense because from speaking with some folks, their thought was actually that it might be the path of least resistance may actually be through an 1115 waiver, similar to REM. And so I don't know, I think that's a little bit different than the first portion of that, immediately integrating it within the state plan. So I just say that to say that I think, you know, not to jump too deep into the weeds of how it exactly it's going to happen, but yeah, I think carving out a benefit makes sense.
I would agree, Linda, that we should just say within Maryland Medicaid, to require Medicaid MCOs to provide a palliative care benefit, and then we can figure out which of the 2 or 3 routes makes the most sense to do that.
And not to throw a monkey wrench into all this, but would we want to say a palliative care benefit with defined benefits?
Benefit with benefits?
I mean, defined services.
Better.
Yeah, sorry about that. Does that make sense?
Yes, Peggy, you're only permitted to talk in 3-word sentences. So.
Okay. Gotcha.
All right, thank you.
Okay, so that's the financing here. Okay.
This
The
is Dr. Bowling. I'm sorry to interrupt you. I just have a question to go back to the slide or make a comment. Should also, if we're changing it to benefits with defined services to the other 3C and 3D, note that in there? I'm sorry, it's on the other slide back.
Oh, I'm sorry.
So, yeah, so
Okay.
noted. We see that.
Okay. Thank you.
Sorry, what were you adding to
So
3?
we're switching, we're replacing services with a benefit in 3C and 3D. We have to do a little reworking because then it does say palliative care. That's probably okay as is. 3D is okay.
3D and 3D.
3D is fine as written. 3C needs to be changed.
Okay. Okay. Okay, so the legislation focuses specifically on community-based palliative care. And here we're recommending a broad palliative care coalition, including the groups outlined here to promote palliative care services. This can also be done through the Maryland Primary Care Program, expansion of funding models, and expansion of palliative care in existing community-based licensed programs such as home health agencies and hospice.
So may I say that I feel that primary care established organizations like community health clinics or FQHCs are being left out of this picture. And if we want to expand primary care, they need to be included. The same way that we have mental health and other services embedded in these organizations, we can have community palliative, and we develop that in our agency. So I would encourage, particularly in D, to have primary care-based agencies, because we are able to capture people into palliative care that will not go through the home health and hospice route.
Ben, I know that you had suggested some of the 4B wording with the Maryland Primary Care Program. You want to address primary care agencies with primary care MC, MD, PCP.
So you know, there are a lot of established primary care delivery systems in the state. And they go all the way from small community-based clinics that are very culturally competent to the big FQHCs. And I would not like to see them excluded in these recommendations. So, you know, it doesn't need to be as part of the MD PCP, because there are other providers that are not part of the MD PCP that are very good candidates to establish palliative programs. I think just broadly speaking, we have focused on palliative as sort of an adjuvant to hospice and home care, where it can actually come from the primary care. And it's more embedded in the care of patients that they have been receiving for a long time. And it can sort of facilitate the move into palliative from the primary care world if they are embedded in the same organization. So just, you know, encouraging you to think beyond structured programs, but, you know, primary care delivery services.
So I think it's important to include the MDPCP because it's the largest primary care initiative in the state. I wouldn't disagree with, and I think the way the recommendation is written, by building on collaborative models such as, or including the MDPCP program to better integrate palliative care within primary care delivery. I would note that as part of the MDPCP program, there are entities called care transformation organizations that, because they are larger umbrella organizations that will work with many primary care practices in the program, they have additional capability that they can organize that would be very difficult for individual primary care programs to procure and convene themselves. So I think we want to call out something that exists and is formalized and recognized by CMS, as well as leaving the door open for other, what I would call innovative care programs or value-based programs, as well as community-based organization that foster, advanced primary care delivery, which I think in the literature, when we think about advanced primary care, we're thinking about more than just simply what's conceived of as traditional primary care, but includes behavioral health integration and potentially other services such as palliative care inclusion in that. So I don't think we need to call out every single initiative in the state, but the MDPCP program, because it covers almost 50% of the primary care providers by my estimate, and even more by others, that it's an opportunity we should not ignore.
No, I'm not saying to ignore it, but what I'm saying is the smaller providers that don't qualify to become part of the MDPCP are very close to communities that are traditionally left out of all of this. So if you want African Americans to enroll in palliative care, if you want Latinos to work in palliative care, you have to include the smaller primary care providers in the picture, because that's where a lot of these people go. And if you just point out MDPCP, that's good. You have 50% of primary care providers, but the ones where a lot of the minority people go to are left out. So,
and collaborative models, it also includes some other types of providers.
And I think the term that we're not disagreeing. I think that we're all, if there's something more specific we should add, happy to consider it.
Well, my suggestion is that maybe we should just broaden 4D because, there are freestanding palliative care agencies that might come to Maryland or might establish themselves that are not affiliated with either home health or hospice or primary care. So maybe we can just broaden the kinds, we can say to such as hospices and home health agencies, but not limit it to just those two.
Okay.
Yeah, I think that's a good point. I think we've talked about Iris Care, which has been acquired by Palliative as originally a standalone palliative care end of life provider practice.
Well, I think what Marion's suggesting is under 4D.
I know.
Right, okay.
I understand that.
Okay. Thank you.
Dr. Kearney, can I ask, go back to 4A for a minute, the broad palliative care coalition concept. I'm not sure I've heard that one before exactly. I wonder, can someone say a little more about what they think that looks like? I admire it. I'm be greatly in favor of it. I think that's how California, for instance, got all of their things going, establishing the standard for the benefit, all the clinical indications. It was done by a coalition. And I'm wondering, what is this? I see the groups involved, some of which I'm at least involved in one of them. I'm thinking about, is that a formal organization with funding that meets regularly and moves forward? How do we think of that?
Okay, I mean, we haven't outlined the specifics, but basically, what we're saying is similar to, as you mentioned, what other states have done, to have a broad coalition, including the partners mentioned here as a starting point. And from that, moving forward with a lot of the recommendations to push public education, provider education, and some of the other things mentioned. Peggy?
So I agree exactly with what Chris said, and I'm wondering if we just added one word to that sentence and we started off saying a broad funded palliative care coalition.
Sorry.
Funded. Because
Then who's funding?
state, I mean, that's our recommendation, that the state funded.
Who is who?
Who in the state?
Who?
Who in the state?
What organization?
Well, legislatively, right? Our legislators would fund that, create and
But
develop it.
if part of the recommendation is developing a broad coalition and these other recommendations, I would think whatever bill evolves would have a fiscal note anyway that says, you have to fund this program, this.
Okay,
So,
because I'm just thinking that in the past, we did try to set up a serious illness coalition. And anyway, it wasn't funded. It was that's why we were not able to get it going, I feel like. Would you agree with that, Chris?
I do. No, I'm echoing that too.
Yeah, and I would just say this issue of funding is becoming an issue in other states that have passed legislation but have not passed funding for it. So New Jersey is in the process of having the governor sign a bill saying they should go ahead with palliative care, but there's no money to actually do the community engagement and the financial analysis that's going to be necessary to make that happen. So I think we just have to recognize, whether we call it out specifically in the recommendations or somewhere, that's going to be an issue for us going forward. We've been lucky to get the NASHP help, but it's not going to cover everything we're going to need to do.
so Ben, you have any thoughts on adding funded to a broad coalition? Or do you assume that they know it will have to be funded?
I'm fine with including funded.
Okay. All right.
The funding then becomes how much funding for how long, but
Yeah.
I think
Exactly.
Okay.
It's a start.
that's something, sending a signal that you can't do something for nothing typically.
Okay.
And I think when we do this, we think about whether other entities, that have already funding, could be the host for this coalition work group, whatever we call it. But I don't think we should, at this point, be talking about necessarily new funding, given the recent revenue write-downs and feeling that the budgetary outlook for the state is as promising as it was a year ago. So.
But shouldn't they say they don't have money? And our recommendation be that they need to spend money in this because this is important?
I think that's what we, are thinking, that that we do include funded, but I am just telling the work group that I think as we think about this, if it does become incorporated in legislation, that some flexibility is going to be necessary.
Sure.
Okay, the next section is on quality improvement, and The way this is drafted here, quality is addressed initially through licensure. Now, there are the current licensing regulations, Comar 102401, require, they're for general acute care hospitals and chronic hospitals, and they require hospitals with 50 beds or more to have a palliative care program. And their regulations definition is very close to the CAPC definition. There is currently no unique Maryland license for palliative care. We can try to build on the existing model. So we can have some discussion on the 5A, the licensing part. 5B is basically annually updating the verification in the provider directory, which we'll discuss later. And 5C, and Peggy, I think this addressed some of your, do have standards requiring new and existing palliative care programs to meet the national consensus clinical practice guidelines. Then, should we get into the licensing alternatives? Okay, because one of the questions that came up is, how do you deal with the licensing when the licensing is only written for hospitals? And you could add palliative care requirements to licensing for hospices and home health agencies, which are licensed entities, but that would then exclude other types of palliative care providers. So one of the things that CAPC has on its website is, when I check licensing requirements, is certification and accreditation, which may be a broader approach. So according to CAPC, CHAP includes accreditation, palliative care, community-based accreditation for hospice, home health, assisted living, skilled nursing, and physician practices. The Joint Commission also has community-based palliative care, and California uses that accreditation for funding palliative care programs. And then HCHC also has community-based palliative care. So one approach that doesn't require licensing would say community-based palliative care programs have to be accredited by one of these, or an accreditation organization recognized by CAPC, because that's going to change over time, and we don't need to list specific ones. But
yeah, if we're talking about a palliative care benefit, then I think the question of how do we recognize palliative care providers becomes more important. We considered licensure, and there were some real concerns about who's actually providing palliative care today, may be pushed out of this service sector if we required licensure, specifically physician practices, QHCs, et cetera. So we thought perhaps accreditation might be a middle ground for formalizing it. I mean, certainly credibility is awarded when entities get accreditation. But I think at where we are today, we don't necessarily want to push providers that are delivering certain aspects of palliative care but don't meet the CAPC definition at this point, to squeeze them out of delivering these services until we know the nature of a benefit, if any, and what the appetite is for more formal licensure. I think we're at a point where licensure might be premature. But I'm open to comments on that.
Yeah, Ben, this is Mary, and I would agree with you. I think we should take advantage of states that are farther ahead of us. And California is a perfect example of where they decided not to go the licensure route, but the accreditation route. And there are now multiple accreditors, so or certifiers, or whatever you call them. So it wouldn't be a restraint of trade to force people to get accredited, because they have a choice of various different organizations that would help them do that. But it would be a way to do something to ensure quality, because they're providing care to a very vulnerable population. And without licensure, the state isn't going to be inspecting, so who is going to be watching out over these people? I think accreditation is the right way to go for the foreseeable future.
Yes, that would replace 5A. I mean, some wording along those lines. Dr. Kearney, did you have on that?
I do. I'm certainly worried about licensure as really not obtainable for us at this point. Accreditation is not a walk in the park. Frankly, I had personal experience within MedStar of becoming the first palliative care program in the state to become accredited by the Joint Commission, and it was not a picnic.
Well, but that's the hospital programs. The ones for community-based are more realistic.
No, I'm in support of it. I didn't mean to say I was not. I just said I think accreditation is a bar that would be that would be very useful for us to say we are operating with quality standards. So I'm in favor of it, but I wouldn't say there's a burden for that as well for anybody involved.
Absolutely, I think that is correct.
Yes, this is where the lack of federal regulations for palliative care is a problem. Because if there were federal regulations, we could just follow those, but there aren't. So, this is where states are making it up until hopefully the feds will come around at some point and help us out here.
Right, it's a Wild West. Okay. The last section of recommendations is data collection, and this is derived from our experience with the statewide palliative care survey and the issues in trying to get that implemented. Basically needs to be streamlined, focused, administered every 2 years, including outreach to stakeholders and enhanced web-based process. So I know it's hard to read this slide, but again, these were all distributed in the mailing.
Linda, does this address the issue of funding as well? Because we've talked about having a registry and sending the survey out every 2 years. Who's going to pay for that? Other than your department, right?
Ben, you have any funding sources? Or again, I don't know to what extent it has to be mentioned if there's legislation that funding is needed.
I think for the survey that we would do, we would say we would complete that with existing resources.
Sorry?
I said, I think from the standpoint of MHCC's work, we would say we would complete that using existing resources.
Using, okay.
MHCC resources, existing MHCC resources.
Under 6B.
Under 6B.
You just put Ben's bank account underneath that, so
Right.
Okay.
everybody will know.
He
All
can
right.
never retire because his successor is going to be stuck.
Right. You see anything else on the?
So on 6C, how does that differ from the Palliative Care Coalition?
Yeah, I was rereading it and realized that there's the Palliative Care Council here. It should be the same as the one under 4. That's the, whatever it was called there, Palliative Care Coalition. Okay.
In terms of the survey, just thinking out loud, given that we survey hospices, home health agencies, and nursing homes today, and hospitals, there would be some thought about whether a palliative care segment be added to each of those surveys. Now, it is expected that additional palliative care providers would enter this market if it was more formalized. We'd have to wait and see. Those were largely physician practices, FQHCs, et cetera. But I think the reason I'm confident we could do some of this survey work with the existing resources is that I think it would be welcomed by the industry if we added it as a segment to an existing survey rather than presenting them with a new survey, to the extent we can do that.
Yeah. I would agree with that, Ben. Also, though, I think too, we want to keep in mind that some hospice providers, I don't know how it is for other associations or networks, but some of our members do have actually separate standalone palliative care services, if you will. So just keeping that in mind. So what they would do is, I'm sure, just send it over, I guess, and, you know, ask that portion of the business to complete the survey.
Yeah, right now, as you know, as part of the hospice survey, we do ask just a general question on palliative care visits and revenue. But I know we've gotten, at least when we get to the provider directory, there's some where there's two components, the hospice component and palliative care. Okay, and as I'll mention later, if anyone has any comments in the next week or so, send them over here. So for now, Rebecca's, we're going to move on to.
So before we leave the recommendations, what's the window for additional comments from the work group?
Okay, if there are any additional comments, we'd like to get them no later than Monday, September 11th. So
About a week and a half.
time with the holiday, because we've got to move ahead and get the report done. Okay, so the state table was sent out in the mailing and updated from what you saw previously with some of the recent NASHB additions. And Becca, take it away.
Sure. So I'm hoping that all of you have in front of you the state table that Linda just referenced that we provided to you in advance with the materials. Just to give you a little background about why we put this together, as Dr. Grant has said, as well as Peggy and others, that really understanding what's happening in other states is important for us to help us understand how Maryland compares to those states, where there might be opportunities to mimic or use those other states' programs as a basis for how we can be successful in the state of Maryland. So overall, the state table that we put together is very short, if you will. We picked 12 states that were really focused on innovative programs that are doing a lot with their programs for their workforce, for quality improvement, for new legislation, new funding, different types of models that could potentially be useful for Maryland to take a look at. But just to give you a little background within that, it's really important that we continue to look at these different state reforms, because we know they are comprehensive. They're increasingly prioritizing comprehensive and coordinated care for serious illness. So it's showing us how other states are really presenting this information and placing more importance on palliative care in their state. So within that, we can look at cost savings. We know that studies indicate that integrating palliative care can lead to substantial cost savings, especially for those that have serious illness. So state governments under constant pressure to optimize healthcare spending stand to benefit from these cost reductions. Then we can talk about lower hospital expenses, decreased ICU admissions, which we know is particularly crucial in states where healthcare systems are overburdened or underfunded. And then we can talk about quality of life. So I think quality of life is the most important area, because we know that palliative care impacts patients' well-being, not just physically with their symptoms, but also providing emotional and psychological support. So we know that by enhancing the quality of care, states can improve patient outcomes and satisfaction, metrics that are increasingly being used to gauge healthcare system performance in a value-based healthcare system. We can talk about also equity and access and policy synergies, but we just wanted to be able to put this information as a way to really reassert how important palliative care is for the legislature and to show how Maryland does compare to other states. Next slide, please. So this slide just outlines how we picked the 12 states that were included in the state level analysis. We wanted to look at a variety of things or parameters to help us focus on which states to select. So we looked at legislation, education, workforce development, quality, and data standards. And each of these domains we know has a really direct impact on both the delivery and quality of palliative care services. So the tables that were included in your materials for today go over a snapshot of, if you will, of some of these state level initiatives to aid really in, as I mentioned earlier, the comparative analysis and to identify best practices or areas that require policy intervention. Next slide, please. So this table, I apologize, I know it's a little bit hard to see, but I wanted to give you a visual. This is directly from that summary that we did provide to you. If you do have that in front of you, it's easier to see, please do take a look at that. So as we mentioned, the National Academy for State Health Policy, or NASHP, has released a comprehensive report just last month in July. And it really highlights on this particular table, it's the legislative actions and budgetary actions in palliative care across 13 states for just 2022 and to date for 2023. I do think it's noteworthy to call out that it does actually demonstrate or show the work that Maryland is doing with the work group that you are all participating in, and this is available on their website. So that's really great to be able to see and demonstrate to other states how Maryland is being proactive and focusing on palliative care. The actions that these different states are focusing on range from statutory mandates requiring healthcare facilities to disclose unavailable end-of-life services to the establishment of pilot programs and public awareness campaigns. If you're looking at New Jersey, New York, several states have also focused on the expansion of community-based palliative care services, for example, in Illinois and Indiana, while others have prioritized enhancement of existing advisory councils or quality of life initiatives like in Maine, Tennessee. And some other states have allocated specific budgetary funds for pilot programs in pediatric hospices, for example, in Virginia and Washington in their 2023-24 and 23-25 budgets, respectively. So overall, the actions demonstrate a multifaceted approach to palliative care encompassing legislative reform, budget allocations, and public awareness, really suggesting a trend that is going more towards comprehensive and coordinated palliative care initiatives at the state level. Next slide, please. So this is just calling a little bit of the information that's from that larger chart. I know we don't have time to go into this and into all the details. We put a little bit of information about what's been happening in California, Colorado, Hawaii, Massachusetts, as well as all the other states like Arizona, Colorado's already listed there, and others that are included in the larger chart. The question that we had for you today is looking at the chart as it's currently provided in the Word document. What do you feel about the usability of the tables? Is it something where it is a good background, a good summary? Is it something where it's too extensive? We need to simplify it. Really wanted to get a sense from the work group. How useful do you think this table is going to be for somebody that might be reading the final report? And I open it up to the work group, whoever would like to comment.
I enjoyed the report myself. I would wonder how many people would actually look through something as lengthy as that, frankly. I'm I shouldn't say this, but in my world, of trying to promote palliative care, and in back some time ago, convincing the administrators in a hospital setting, for instance, the quality part always had to be what we talked about. You could never, say we're trying to save money, but otherwise, if you weren't saving money, they weren't that interested in your topic. So I'm wondering in your work, who as you go forward, who would be most convincing about cost savings to the state? Who has actually demonstrated that? Maybe Marion knows, or some. I don't know whether California has actually been able to demonstrate, or Hawaii have demonstrated literal cost savings, because that does get people's attention, assuming the quality is there as well.
Maybe
Yeah, I mean, I don't know that the state Medicaid programs have run long enough to show cost savings, but there is a body of evidence that everyone is basing their state projections on. A lot of that is published. And so I think that's the best we've got. It's from private experiences, it's payers doing, their own thing, reporting, randomized controlled trial. I mean, PCORI stuff, that kind of thing. So I don't know that we've got robust financial data on a state basis yet. First of all, I want to thank you for putting the chart together. This is an amazing compendium. And having put it together, I think it ought to go somewhere. The question is, whether it goes into the report is maybe too much, but a link to this somewhere on your department website where people who do want to get down into the nitty-gritty, I think would be very helpful. Now, this changes over time, so it's going to only be a snapshot for the next few months, and then there'll be other things happening in other states. But I really think we should make it available to people who would maybe want all the detail, but certainly get some of it in the report. Thank you.
I think what we envision is a description, a general description and summary in the report, and then having the table as an appendix to the report if people want to read the details.
That
Yeah,
sounds good.
that section summary, I think, we need to emphasize the key commonalities across the state and highlight states that have made
Yes.
significant progress as opposed to, I think some of the readers, Dr. Kearney's probably close to being accurate, although we hate to admit it that sometimes less is better. I think it can exist on an appendix basis, but we can characterize things that are being done by all states and features that seem especially impactful, be helpful to people who at a glance want to see what's happening here.
Yeah, I agree with that, Ben. I think she's listed the states that, generally in the last years, people have been looking to: California, Hawaii, Massachusetts, and Colorado. So highlighting, the impact, they are, they're much, some of them are much further along than others, as you say. So I'd be interested as a legislator to see what could be done, not necessarily all 12, digging through all 12, but so I agree with that.
I also wanted to say, I agree as well. I think this is a tremendous resource, and not just for us to have, but quite frequently, I'm asked to give information for my colleagues. We actually have a monthly meeting from across the country, and we share information. I think it's so important to be able to have this information and to be able to, share it with each other, because it really does spark innovation and new ideas and new practices. So I'm very grateful to have this. And as far as research on the savings of palliative care, I did want to mention that the National Hospice and Palliative Care Organization recently did some work in this area. There was a report issued. Linda, if I can find that, I will go ahead and send that to you to share with the group. But thank you. This is really great.
Any other comments?
Anything else? Okay, second portion for Rebecca is the palliative care provider directory, which we've discussed this during the survey process and how best to summarize and present this. So Rebecca, you want to go ahead with this?
Sure, I'm happy to. Oh, you're already on the next slide. Perfect. So as Linda mentioned, part of the work that we're doing with this work group is to put together this directory to help people find palliative care providers. And what we focused on in this palliative care provider organization directory is twofold. So we know, as we've talked about earlier, that all of the hospitals that are 50+ beds are mandated to have a palliative care program. So we want to for sure include those in this list of palliative care providers for the state. But then we also want to think about other community-based or smaller non-hospital organizations that are providing palliative care. So we looked to those that had participated in the 2023 palliative care statewide survey to understand who has indicated they're meeting the CAPC definition for a palliative care program, to include also those organizations in this list. So this list serves as a guide, if you will, to palliative care provider organizations in Maryland for the year of 2023. The aim is to assist healthcare practitioners, policymakers, and other stakeholders in making informed decisions related to palliative care service availability, as well as providing information that can go out to the public, to families, caregivers that are looking for palliative care providers for their loved ones. We feel like this tool, if you will, offers an opportunity to understand the landscape also of available tools. So we know that palliative care is not equally distributed across the state. So there might be an opportunity to be able to promote future research or identification of new resources that need to be able to be made available to different parts of the state to provide palliative care. I'm hoping you all have your materials again in front of you that Linda sent to you with the directory. As of right now, just to go over what's in the directory, it's pretty basic, if you will. We did try to include the most up-to-date recent current information with different name changes from all the different organizations that seem to change or get bought out. Wanted to provide this as of, I think the date is October 22nd, August 22nd, not October, 2023. These are the most current information that we do have. So it lists the organization name, the type of the organization, looking at really the organization types that we focused on in the survey that we conducted, of hospice, home health, hospital, and nursing home. It provides the current physical address of the palliative care provider organization. For those that are home health, for the one that's included in the list right now, it provides their office location, because obviously they're doing home health and not providing services at that location. We listed the most current phone number, website that we could find for the organization as well. As I noted, a lot of the organizations are constantly getting bought out or switched or moved around. So trying to keep that up to date is something that will take a little bit of extra work in the future. We do also provide 2 specific columns in there, and this is part of the question for you all today, whether or not you feel like it's important to include that. One is, did they participate in the 2023 palliative care survey, yes or no? And then, are they a palliative care provider, which is a little bit of an oxymoron because this is a palliative care provider organization website. But what we're going by that is really understanding, did they meet the CAPC definition that we provided, or are they a hospital? That's how we included them in that last column there. So we're trying to understand from the perspective of putting this out for your professional purposes, but also for the public. Are there any critical gaps in the type of information that's currently provided in the directory? Are there any additional data fields we should include? How useful do you think a provider directory like this would be for either your own organization, your personal review, or for your professional review? An issue that we do acknowledge, and I'll note that there are 2 important footnotes, disclaimers that this is based upon the survey, and this is based upon what we know are mandated to be palliative care providers. So we could have missed somebody if somebody didn't choose to participate in the survey. And so that's what the 2 footnotes are out about there. But just wanted to kind of get your feedback about the utility of this directory. It looks like Kathy Hamill has her hand raised.
Kathy?
Yeah, thanks for putting this together. My question relates to, for example, when we think about Gilchrist, we have programs in hospitals, nursing homes, and hospice. And so I'm wondering how the categorization was done.
That's a good question. So it's based on how they self-categorized from the survey if they're not a hospital. So I don't recall Gilchrist where it ended up being categorized on
the survey.
Yeah, off the top of my head, I don't know that one.
Yeah, I think we struggled with that on the survey of categorizing ourselves. But for example, the program that is at Greater Baltimore Medical Center is actually a Gilchrist run program.
Okay.
So if we could just do some work on how how to work on that categorization.
Sorry,
My
what
concern, of
question?
course, is that the hospice designation will assume that the only type of palliative care we do is end-of-life care, which is not the case.
Mhm.
Kathy, what were you saying about the other program at the hospital, what it's categorized as?
Well, under Greater Baltimore Medical Center, which has a program, Gilchrist is the provider
Okay.
at Greater Baltimore Medical Center, and we're the provider at a number of different hospitals. And my concern with categorizing our palliative care program as part of hospice is that it's going to be perceived to only do end-of-life care, which is not the case.
Would it be better, Kathleen, to categorize Gilchrist separately as, I think Linda was mentioning this earlier, like a palliative care provider, like a larger scope?
I think so, because we're accredited for palliative care.
Yeah, Kathy, I remember when we heard back from some nursing homes, or even looking at the CAPC directory.
Yeah.
The nursing home care was provided by Gilchrist, not the nursing home. But
Right.
the nursing home may well have responded that ABC Nursing Home has a program.
Had a program, right.
So I don't know, Rebecca, if there's a way to add a note that says provided by Gilchrist, palliative care, or whatever.
Yeah, we saw that in a lot of the survey language, that it was like a nursing home or even a home health not home health, the hospice organization that had like a separate organization like Gilchrist come in that was actually doing the providing the palliative care. What was interesting actually during the survey itself too is some organizations took credit, if you will, for providing palliative care, and some said, no, you need to go talk to the actual like providers of it. So there's a little bit of a disconnect in there. But we could certainly add a third asterisk, or we could figure out a better way to do that as well with a column to indicate that they're a palliative care provider for other organizations.
Kathy, could you provide that to Rebecca as to where you're the provider? Maybe.
Sure. And I guess my overall question is, does that designation help? I guess what are we trying to do with this is a hospice base, this is a home health base? Like, does it?
Maybe it's not really needed.
Yeah, I don't think we.
Because I think it reflects the complexity of the situation, is that it is provided by so many different types of entities that I'm not sure we are ever going to be able to come up with the right categories.
Well, into Anna Maria's point, if we when we see primary care, what are we going to do? Are we going to call them primary care palliative providers? Like,
Not when, we already exist.
no, when you're listed, because I don't see a lot of them.
Because we don't get the survey.
Well,
right. So I'm just supporting your comments earlier about where does that all fit in? And if it really becomes part of the MDPCP program, how is that going to get categorized? And
but I love the idea that there's going to be an asterisk that says whether you participated in the survey or not, because I think we found a way to get people to participate in the survey is to get themselves on the directory.
Right.
Yeah,
Who gets the survey is a big question also, right? Because people would be willing to answer the survey if they got it. And so how do we look at that if we're going to move this forward? And may I say, there's a big category missing here, which is language competency of the service. Because, palliative and end-of-life care is particularly sensitive to language competency.
Mm-hmm.
So it would be good if it doesn't mean that all the staff can provide services in the particular language, but if enough staff can use that language, it would be good to have it stated.
Like whether or not they have palliative care interpreters, or like what exactly would you ask for that, or like materials or services, or
someone actually comes in, a Spanish speaking family,
mm-hmm.
will they have enough staff members that can deliver services in that language, or will they have to use interpretation? Because it makes a
Okay.
big difference when people come to so we speak 4 languages. When people that speak those 4 languages come to me and say, can you refer me to somewhere? I'm like, I have to ask them, are you okay with using interpreters, or should I look for you with someone that speaks the language? And most people don't
Sure.
want interpretation services.
Okay,
So, mhm.
good.
So I think in general, there's probably some items here regarding characteristics of the entities, that language service is a good one, but yeah, I think there are others. And we also want to, I think, flag those that have CAPC certification. There's some characteristics we're not initially planning to collect information directly on quality, but any certifications.
This is the result of the existing survey. Those can be future iterations.
Exactly, right, yes.
And-
And language would, but features of the provider, I think, are, going to be valuable. And
So
Yeah.
another big feature that I think is really important to patients is whether they have to go somewhere or the service will come to them, whether it's home-based or nursing-based, whether they have to commute to get the service or receive it where they are, is a huge issue for many patients. I mean, they don't care if it's hospice, home-based, nursing care. They just want to know, do I need to find transportation to go there, or will they come to me?
And in future surveys, we also want to be sure that we capture, the area where the entity is providing service. How broad of an area?
Well,
Consistent with the transportation question.
right now, it's categorized by the type of provider. And as Rebecca mentioned, if you're a home health agency or a hospice, you have an office location, but that doesn't describe what jurisdictions you're actually providing care.
And it doesn't say if it's an inpatient or they'll come to you at home. I mean, I think, and honestly, you need to account for these categories are for a group of people that actually work this day in and day out. When you try to put this in the community, you need to translate it to what is important to them. And whether it's hospice, home health, hospital, they don't care. They just care, is someone going to come home to take care of dad? Or do I have to figure out how to get dad there?
Yeah.
I want to highlight how important is what Ana Maria is saying right now, especially for rural areas where it can take you up to an hour or an hour and a half to get to any provider. That without mentioning the difficulties of insurance coverage. So thank you for that, Ana Maria.
Can you repeat what you just said so we could hear it? Wasn't as loud?
I'm saying, this is Monica Escalante with Coastal Hospice, saying that it's very important to, in the surveys, capture whether the service comes to the patient or whether the patient has to get to the provider. Because that's a big barrier for care in rural areas where many of the patients have to travel an hour and an hour and a half to get to a provider. Never mind, that's without mentioning the barriers that insurance coverage provide to them. I'm particularly concerned because so many people are going to lose Medicaid coverage in the months to come. So that's going to be even a bigger problem for rural areas.
Thank you.
And then if it's episodic or continuous, right? If it's in the hospital, it tends to be more episodic, but is this someone that you're gonna engage with ongoing care? I think is also something that our patients want to know, what are they signing up for?
It's really helpful information. Thank you, everybody, for the comments. I think one of the interesting things will be to see moving forward to what the state might be able to do to include some of the quality information. If there's a way to get more of that information, whether it comes from whether or not they were accredited, if we go in that route, if that gets approved. I think that information from a quality and population health perspective of the patient and family and caregiver is almost as important as the location, or do they come to me? I want to be able to say this is like a 5-star versus a 2-star, all of that sort of information that a lot of organizations, including states, are trying to do to be able to benchmark, to compare one organization to another in a very objective way.
I was, hold off here 1 second. I wanted to reach out to our folks from Aging that are familiar with the Maryland Access Point program. What type of information do you think would be helpful for those organizations that are engaged at a county or small area level to support the work that the Access Point groups are doing?
In looking at the list that was created, I mean, I thought that what was there was a wonderful list, and having the contact information and the types of services available, it is really kind of what we need to get started. I think the training that's proposed through the recommendations will really go a long way at allowing Maryland Access Point to better understand palliative care and make referrals. So having that contact information would be helpful. I really, truly agree with Anna in that having information who offers translation services, if there is an opportunity to share information about wait lists for services, if that exists, or if there's any type of fee for service, and I know that in most cases it's billable to insurance, but having any information around what it may cost individuals, or ways for our team to better manage expectations of individuals when making referrals. So ultimately, what I would really love to see for Maryland Access Point is that, as a result of training and a result of providing this provider directory, that our local MAP offices create partnerships with the providers in their jurisdictions and include them as part of their interagency committee, and have an ongoing relationship and develop kind of that warm handoff piece. So having a professional contact might be helpful as well.
Thank you.
Perfect. Thank you.
May I add, Coastal Hospice partners with the MAC programs in the 4 counties that we serve, but there's not enough palliative care providers as is. And not only is it a concept that is not well understood, there's not enough providers to do it. So that's why I really like the recommendation that was made earlier about expanding the availability of providers beyond hospices, home health agencies, and others, because that's part of the problems with some of the potential referral sources, that you can't promote something that doesn't exist in your area. And that's very much the case in Wacomico, Worcester, Dorchester, and Somerset counties.
Thank you. Rebecca, I think you had additional questions on the directory.
I think we've gotten through most of them. I kind of talked through them a little bit, but any other comments? You can see the questions on your screen, or any other feedback. As we mentioned, we're looking at updating this survey. Now I'm blanking. Every year, I think this directory every year. Right. It'd be something that I don't know, Linda, you and I didn't talk about funding, but we seem to be on a funding streak in our discussions today, like how that would be funded, if it could come under normal MHCC duties, or how that would move forward.
Yeah, we've already discussed Ben's bank account is covering.
Oh, okay. All right. Got it. Send me that routing number and we'll be good.
One question was the last 2 columns, and whether those are needed in the directory, or having the asterisks are sufficient, that either they're a hospital that's assumed because it's a licensed hospital of 50 beds, or someone who participated, and whether I think it's helpful for us in our discussion to know they were in the survey, they weren't in the survey, and you can check your providers, but I don't know if it's needed in the directory because it makes it kind of more cumbersome to look at, so that was one of the questions we had.
Linda, question, is it helpful to break it down between inpatient palliative care services and community-based palliative care services?
Well, it's broken down by provider type.
Right. But some hospitals are doing community-based, right? So they are going to homes, the way I understand it.
I think that's correct. I think that if you're going to take those last two columns don't help me much, but whether they provide, you know, if they're inpatient setting, do they provide palliative care services there? Yes. But then do they also provide outpatient services? And are they home? Are they actually office-based palliative services where the patient has to come to the office to be seen? Or are they actually home-based or virtual? Ability to do virtual care would be much more relevant, I think, to a lot of the questions we've been talking about here today. So I don't know if that can be included in the directory questions, but that's what I think I'd want to know.
So
Yeah,
Rebecca, I guess the question is that data available? Do we have that level?
I don't think we have that granular level of data at this point. Just with some of the issues that we ran into with the survey, like I mentioned, with some responding, like we had some palliative care providers responding for a nursing home and some nursing homes responding for themselves as if they were the palliative care provider. So to know exactly where they provide services, we didn't have a specific question that says, do you only provide services in this location or in any types of location? It was more based on what the organization type was. I think for the future, though, that's something that definitely we could put that in the list of recommendations for an update to the survey, that it could include, or to the survey and to the directory, that it could include more information to the point that's been made about where do you provide services? Do you drive to someone's home, or do you have to have them come in? That could help with alleviating some of those concerns from the rural populations or those that just don't have access to transportation.
Yeah. And just to expand further on that point, I'm just thinking about the kind of calls I get from people who say things to me like, yeah, the average consumer, and usually they're elderly and they're having a hard time even understanding what palliative care is. But they'll say, I get things like, I just came from my doctor and he said, I need palliative care services. Where can you recommend? Well, if you're looking at that list and consumers will be using it, you say to yourself, well, we have a lot of nursing homes that provide palliative care services, right? So if I'm going into a nursing home, maybe I want to look at that. If I need, as everyone has talked about, rural community-based type services, you want to know that that's available. So I think it would be very worthwhile to kind of be specific about that kind of information and where the services are offered.
When we can get that.
When you can get it. Next survey.
So, yeah, I did have a question for Aaron on the hospital. Does the MHA maintain any information on characteristics of hospital-based palliative care programs, such as the point that was raised earlier that some hospitals do have community-based programs, some don't? Any information that MHA collects?
We have not collected that information in the past, no. And I will say the breadth and arrangement of services in the hospital does vary quite a bit.
Ben, I would like, this is Monica Escalante, I would like to mention that I forgot completely about Ana Maria Izquierdo's Care for Your Health organization when the survey was happening. I neglected to recommend the survey going to her. I've known her for many years, and she has the best established home-based palliative care that I know in the state of Maryland. And I feel so sorry to have seen her recently and tell her about the committee, but I think it's a little late. But maybe the group may benefit from understanding some of the things she's been doing, because she's been doing home-based palliative care with outstanding results, both in Prince George's and Montgomery County for many years. I don't know if it's of any value for her to share some of that.
Yeah, if you wanna, just tell us briefly about the program.
Sure. So we started Care for Your Health as an elder care organization, and the community palliative program came out as a natural consequence of taking care of old people. So we do longitudinal aging care from the adults. We take care of the caregivers and the elders, and we sort of moved into home care. And what happened is that there were people that wanted to continue to do just primary care at home, but there were people that are moving more towards a more palliative. So we started both in the office and in home. We started having this service line of palliative care at home. And the thing is that it is very interesting, because what happens, and what I think is so interesting, is that we have people that do only palliative care. We have people that do only primary care, but there's a significant chunk of people that are in this in between, where we do both things, where we code a palliative care visit, but we're also doing primary care at the same time. So I think there's this space where people are interested at sort of starting this conversation with someone they trust, because they've been our patients for many years, but they still want to continue to do, like they will drop the preventive care, but they will not drop the chronic care management, for instance. And it creates these three sort of lines of care, which is one more preventive primary care focused, one absolutely palliative care, and then this middle kind of service line that is very useful for a lot of our patients. We actually measure our place of death for our patients. So we are 80% of our patients die home, and only 10% of them die in the hospital. So in terms of cost, I cannot give you a dollar number, but it makes a big difference. The healthcare system is paying when most of your patients die at home. Our main issue is sort of what you guys were saying before, right? If you look at the E&M reimbursement, I get paid $140 to see a patient for 25 minutes in the office, and $135 to see a patient at home for 40 minutes. So the sustainability of this service is not there right now. Unless we do things like you said, like carve out funds to do this well, I don't see other providers jumping and doing this if we cannot pay them the right thing to, the quality of care that our patients get, and, the savings to the system. So, and the other thing is that we were able to hire providers that mirrored the community we were serving. So we have African-American providers, Latino providers, white providers. So that also brings a little bit of the cultural competence and linguistic competence to the table. So I'll be happy to share more of our program, but it's quite distinct than the one that come from hospice. I actually work with Montgomery Hospice Palliative Care Program, and it's different because we can sort of flip people around from primary to palliative very easily. So
what type of licensure is your agency?
We are a community health center, so we're licensed to be a community health center. We are not, we don't have a hospice license.
Okay.
Thank you. Questions?
No, but it's wonderful to hear about your program, Anna. Thank you so much. But I think this is a perfect example of the heterogeneity that we're going to see in this space, because it isn't a federal benefit, because it isn't a condition of participation regulated industry. You're going to have specialists. You're going to have oncology programs that are going to have palliative care integrated and maybe very robust, could even be home-based. So I think we have to just figure out, we have data right now from the survey. We've got to organize it as best we can, but we just have to recognize that this is a moving target. And ideally, when a benefit funding for a benefit would come from the state in Medicaid or something, it would be interesting to see what springs up to meet that need.
Thank you.
Thank you.
Rebecca, did you have Any other questions?
No, I think we're good there. I thank you all for your feedback, and I think we've got already some really great ideas how to even improve this for the future. And you'll see it in the next version that comes out when we update it just a little bit more.
And did you have? Yes. As I mentioned earlier, if you have any other specific comments, we mentioned some of the comments on the directory, send those to me and Rebecca. And if you have any comments on the recommendations, I will need them no later than September 11th. Because as you know, we're on a tight time frame. We will be presenting this to the commission at its October meeting, which will be October 19th. And the final report is due to the Governor and General Assembly on November 1st. And so we just want to thank you all for taking the time to represent your organizations, participate in the work group process, share your thoughts with us.
Are we really done? We're not going to meet again?
You're welcome to.
You certainly are welcome to come here anytime.
To drop by anytime, okay.
So I think that informally, you'll remember that the NASHB funding continues for another year. And I can conceive of activating the group periodically to share with you or engage the group in some of the work that NASHB is undertaking. Certainly, members are free to attend the presentation on that's October 19th. Is that correct? And we don't have anything formal planned for speaking. Typically, our meetings cover a pretty wide range of topics because of the charge the Healthcare Commission has. But certainly, if you do attend, the chair will recognize you, and if you want to hear firsthand the staff presentation, you're most welcome to either attend in person or virtually, because our meetings continue to be hybrid. I want to thank everyone for the attention over the last year. I think everyone has learned a lot, even though some came with more knowledge than others. Particularly, I want to thank the Department of Aging for elevating awareness about the Maryland Access Point. That does seem to be an opportunity for the Healthcare Commission and the Health Department in general to reach down into communities to raise awareness about a range of services. Of course, certainly palliative care, but other areas as well. So thank you. Also want to thank our colleagues at the department as well as Department of Aging and all of the members of the service group. I'm not going to give you my banking account number, however, but I guess some of you have ways of finding out better than others. I'll leave it to the experts. Thank you very much. Have a nice afternoon and a great Labor Day weekend.
Ben, can I quickly thank Linda for becoming a palliative care expert in about, a few months? It's really been quite impressive. So thank you. It's been a pleasure to work with you all.
And can I ask, just where does it go in the legislature when it arrives there? Who handles it?
Oh, in terms of the report will go to the standing committees, and then I think once the session starts, we'll have to see if legislation to formalize some of the recommendations is introduced or not. As I said, I think where we started 2 years ago was the funding outlook for the state was very, very promising. It doesn't look quite as promising today. There are a host of initiatives, not only in health, but education and transportation that are priorities for the Moore administration. But healthcare continues to be a priority. Keep in mind that you have a technical term when you're talking about legislation, multiple sessions to consider. Obviously, The first two after a report comes out are probably represent the most opportune times. But various groups will be considering whether they put forward legislation this session or wait till 2025. But the reports typically, if they have any impact, do generate legislation. Right now, and keep in mind that we are dealing with a host of agencies within the department that have standing on this, that the Healthcare Commission at this point doesn't plan to introduce legislation, but we will be working with our partners in the department over the next 4 or 5 months to see if a consensus legislation could be introduced. That also doesn't preclude the fact from stakeholders in this group working together to introduce legislation. That has happened, and in those cases,
My money is on Peggy.
So hope that helps.
Yeah.
Thank you.
All right. Thank you very much. I appreciate everyone's participation throughout. Have a nice afternoon.
Thank you.
Thank
Thank
you.
you.
Pleasure working with everyone. Thank you. Have a good one.
Bye.
Bye-bye.